Welcome to the Heart of Prevention, helping clinicians stay up to date on preventive cardiology. This show features leading experts discussing real-world strategies to prevent heart disease, from lifestyle changes like diet and exercise to medical treatments, including new therapies. Whether you're a medical student, resident, or practicing clinician, this podcast challenges, informs, and enhances your approach to cardiovascular disease prevention. The Heart of Prevention, keeping hearts healthy one episode at a time. I'm Dr. Michael Shapiro, President of the American Society for Preventive Cardiology, and now here's your host, Dr. Keerthana Pakanati.
Dr. Blumenthal, Dr. Gluckman, welcome to the Heart of Prevention.
Thanks so much, Keerthana.
Thanks for having me. I'm really excited to be here.
The feeling is very mutual. So as you guys know, I'm Keerthana Pakanati. I'm the host of the podcast. But before we dive right in, let me tell you how lucky we are to have our guests for today's episode, where we're going to be going over the 2026 Dyslipidemia Guidelines Playbook. Dr. Roger Blumenthal, who really needs no introduction, but I'll do my best here, is the Kenneth J. Paulin Professor of Cardiology, Professor of Medicine, and the Principal Developer and Director of the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. He's the 2018 recipient of the Landon School Anthony Kupka Distinguished Alumnus Award, the 2019 recipient of the Society of Cardiovascular Computed Tomography SCCT, Arthur S. Agatston Cardiovascular Disease Prevention Award, and the 2025 recipient of the Joseph Stokes, MD Pioneer in Prevention Award from the American Society of Preventive Cardiology. Aside from being an incredible mentor to a lot of people that are involved in the preventive cardiology space, he's also the co-chair of the ACC-AHA Guideline Task Force Subcommittee that oversaw the updates of all the prevention-related guidelines. He's also on the editorial board of Circulation, a co-editor-in-chief of the Textbook of Preventive Cardiology, a companion to Brunwald's Heart's Disease, and the ASPC Manual for Preventive Cardiology. He previously served as president of the Greater Baltimore chapter of the American Heart Association and the Southeast Lipid Association, was vice president of the American Society of Preventive Cardiology and is currently on its board of directors, and is a former chair of the American College of Cardiology Prevention of Cardiovascular Disease Committee. Not to mention, he is on the Stanford University Elsevier list of the top 2% most cited scientists worldwide from 2020 to 2025, and was the co-chair of the 2026 ACC-AHA Multisociety Dyslipidemia Clinical Practice Guideline we'll be talking about today. And I could keep going, but for the sake of time, I will stop it there. Dr. Gluckman is the medical director of the Center for Cardiovascular Analytics, Research, and Data Science, CARDS, at the Providence Heart Institute in Portland, Oregon, right down the street from me in Seattle. He's an adjunct faculty member of the Ciccarone Center for the Prevention of Heart Disease. Previously, he served as the associate editor of the Journal of the American College of Cardiology, associate editor for guidelines and clinical documents for ACC.org, which is the primary website for the American College of Cardiology, and chair of the ACC's Solution Set Oversight Committee, overseeing policy and clinical documents issued by the ACC. He's a past governor for the Oregon chapter of the ACC and a current board member of the American Society of Preventive Cardiology. He's also a liaison for the American Heart Association Council on Quality of Care and Outcomes Research and a site member of the AHA's Target Aortic Stenosis Initiative. And as I had the pleasure of learning, Dr. Gluckman and Dr. Blumenthal have known each other for a very long time.
Dr. Gluckman and I think, first met, Ty, probably in 2002 when you were a first-year fellow. We've worked together ever since, and Ty is one of the best educators and writers that I know. So we wanted Ty to be a key part of our dyslipidemia guideline, and it was great to work with Ty and my co-chair, Pam Morris, and we look forward to discussing this with you.
And I'll just add, you had mentioned that Dr. Blumenthal, Roger, has been a mentor for so many different people, myself included. I can't think of anyone better. He had an indelible impact on my career trajectory and my interests. So this is even that much more special to be a part of this with him today.
Thank you both so much. So we're going to start off right by talking about the 2026 Dyslipidemia Guidelines at a high level. Can you walk us through what are the important updates that clinicians listening to this should know? And we'll start with none other than Dr. Blumenthal.
Well, Keerthana, I guess number one, we tried to emphasize that we should assess cardiovascular risk early and, if necessary, treat with more aggressive lifestyle changes and, if necessary, medication. We then talked about a CPR strategy of, C for calculate person's at risk of atherosclerotic vascular disease, P for personalized with risk enhancers, and R could be to reclassify if selective use of coronary calcium was used, and then finally R to reassess the need for lipid-lowering therapy. And I'm sure we'll get into the new prevent thresholds and the new LDL goals. But in my mind, I think the key points are LDLs of less than 100, we all should strive for, less than 70 for people at higher risk, and very high risk, less than 55. So we look forward to discussing more of the details with you.
And I'll just add, I think this is always challenging. I mean, this guideline touches so many different disciplines in medicine in general. We're talking about it coming from two cardiologists today, but this extends to everyone from the pediatrics community, where understanding risk in those as early as age 2 for those with familial causes of elevated cholesterol, through our adolescent years, our adult years, into our geriatrics population as well. This touches obviously broad aspects of primary care, internal medicine, family medicine. And, I can't but help share that almost every one of us probably knows someone who's been affected by cardiovascular disease, with LDL cholesterol in particular being a huge driver of the development of atherosclerosis, its progression, and the risk for events. The goal was to try and produce or summarize all of the available data, but also do it in a simplified, hopefully consumer-friendly fashion. And so there was an attempt to bring back LDL cholesterol goals. I think while the concept of treatment thresholds is accurate, it perhaps was confusing to some frontline clinicians. And so really trying to bring back therapeutic targets, aka goals, to our range of different caregivers, I think was really, really important. I think there's also Dr. Blumenthal highlighted it, but the reinforcement of the role of imaging and subclinical atherosclerosis and understanding who may be at particularly heightened risk. There are a lot of new aspects. We'll talk, I'm sure, more about it, but incorporation of lipoprotein A testing, more selective, but incorporation of apolipoprotein B being a reasonable additional consideration. These are all things that help round out our understanding that, it isn't necessarily simple for everyone, and we need to actually personalize our approaches to risk assessment and application of the evidence in terms of treatment as well.
Yeah, thank you both so much. And so in that way, we've talked about some of the things that have shifted here. What was the rationale behind some of these bigger shifts? Were they driven by trial data, implementation gaps, maybe a need to catch the patient earlier, all of the above?
Yeah, I mean, I think it's probably all of the above. Recognize that the last full guideline was published in 2018, so we're 8 years out from that. Admittedly, there was a document on non-statin therapy put out by the American College of Cardiology in 2022, but even that was 4 years ago. So there was new science that helped to inform this. We may touch on it, but there was even new science that came up against the guidelines being published, and how do we incorporate that, including new science that was just presented at the American College of Cardiology scientific sessions just a few weeks ago. I think part of this is also challenged by the fact that observational analyses, whether looking at claims data or electronic medical record data, highlights huge care gaps around under testing. It's really hard to treat what you don't measure. So if you're not getting standard lipid profiles on individuals starting in our pediatric population up through our adult population, it's really hard to know where the opportunities exist. And then those same analyses highlighted and underscored that we have huge treatment gaps. And this applies, you might think, well, that's just consolidated in the primary prevention population. No, we know that in the secondary prevention population, there was underuse of statin therapy, underutilization of the right intensity or preferred use of high intensity statin therapy, and in a range of different non-statin therapies. So I think this was as much about incorporating new science, new evidence, as much as it is reinforcing that what we have talked about doing that hadn't changed, we need to double and triple down on. And so I think we're going about this in modified, in some cases subtle, and in some cases overtly different ways. And then I guess the last thing I would say is, the prevent risk scoring approach to assessing risk is new, but there was some science that highlighted the fact that the previous pooled cohort equations may in some cases overestimate risk. And so this is a way of introducing, harmonized with new blood pressure guidelines, incorporating prevent as well, albeit a different endpoint of interest, nonetheless a new calculator or means to assess risk that we're aligned with as it relates to the blood pressure guidelines as well. So there's more probably to talk about, but those are just some few ideas.
Yeah, thank you. Dr. Blumenthal?
We've also had so much more in terms of advancements with risk prediction. The coronary calcium data has really matured. In 2018, we uh, increased the strength of evidence for coronary calcium from the prior 2B to a 2A level of evidence. And then in this document, we felt that the best tiebreaker we had in terms of when a person was uncertain what their true risk would be a coronary calcium scan. Doesn't mean that everyone needs to have a coronary calcium scan. I personally order relatively few, but I think the use of risk enhancers can be a very useful tiebreaker. And if indeed a person is still unclear what their true risk is, we felt that selective use of coronary calcium could be the best tiebreaker there was, Keerthana, about aggressive how aggressive one should be in terms of pharmacotherapy.
I think something that I've learned, like working with the podcast and getting to hear from a variety of attendings, when it comes to prevention, there really is not one specific thing. We look at it as a conglomerate. We look at it as a lot of different things that add to help us understand a patient's risk, whether that's imaging, whether that's a risk score, whether that's numbers and labs in front of us. And I think what I'm hearing is that, the guidelines just continue to build on how we collect evidence and understand it to help understand our patient's risk scoring.
Well, Ty and I have collaborated a lot on, one of Ty's first papers that we did together was in the Archives of Internal Medicine about the ABCs of cardiovascular disease management prevention, and then with the ABCs of management of acute coronary syndromes. A for assessment of risk. A also can stand for, the appropriate use of aspirin or anticoagulant therapy. B for blood pressure, C for cholesterol and cigarettes, D for diet and weight, D for diabetes prevention or management, E for exercise. So cholesterol is really just one part of the overall prevention scheme, as you were discussing just a few minutes ago.
And I would just add, again, cardiovascular disease, atherosclerotic cardiovascular disease represents the number one killer for men and women alike. And we unfortunately don't do as well as we otherwise could and should. So I think attempts at trying to get upstream and without pushing too hard, I would make the argument that we have more opportunity to better understand the risk trajectory of a given individual and to be able to implement effective tools. And the toolbox has gotten larger that we have available. And I don't want that to be a glide path to pharmacotherapy. All of this starts on a backdrop of important heart healthy lifestyle changes as well.
I love that. The toolbox has gotten bigger. I'm going to steal that and put that somewhere in my own little clinic toolbox. So, are we moving more definitively towards a treat to target approach, or where's the threshold strategy in this, and kind of how have we shifted the pendulum? As you've mentioned, it's kind of gone one way and then back to another direction. And we'll start with Dr. Blumenthal.
So just like with blood pressure, we say that a normal blood pressure is less than 130 over 80, and we encourage less than 120 over 80 when we can. We would say that all individuals who are at, low to, somewhat intermediate risk should get an LDL, but should strive for an LDL at least less than 100. And for higher risk people, an LDL less than 70. And we said very high risk, we joined the European approach to say less than 55. So I think the LDL goals, along with non-HDL and apoB goals, we said that we should try to achieve our LDL and non-HDL goals really before measuring the apoB in most circumstances. But apoB was most helpful in individuals with diabetes or elevated triglycerides, or people who already had lower LDLs in the range of around 70.
And I would just add that most of our clinical evidence from randomized trials, whether active comparator or placebo-controlled trials, have historically randomized individuals to one of two arms, looked at the on-treatment LDL cholesterol level. We just had a trial presented at the American College of Cardiology and published in the New England Journal of Medicine that actually treated two therapeutic targets it really reaffirms a lot of what we had in the guideline, even though the guideline came out before that trial was actually published. So I would say in the world of lipids, we have had fewer by far trials that have been designed to treat to a goal, but we've now seen at least one recent one. At the end of the day, I think a key takeaway is that, and this is, I think, strongly reinforced in our guideline, is matching the intensity of LDL cholesterol lowering to the baseline risk of the individual. We are more aggressive and we push harder for those individuals at higher cardiovascular risk. That doesn't mean that we don't push hard on those at lesser degrees of cardiovascular risk, but it's a world of relativism overall. And I think the recent science supports that, the historical science supports that. And, what I often get from patients and from some colleagues is, well, you just move the bar over time. And I guess the question is, was the bar going back a decade or 2 decades ago simply way too high? And when you look at where people are when they're born, presuming that they don't have an inherited predisposition to high cholesterol or in youth, LDL cholesterol levels taken off of umbilical vein sampling of around 30 milligrams per deciliter, we probably were not designed to have even the LDL cholesterol levels that many of us consider quote unquote low. They're just much higher. And so when we look at trials that originally looked at some of the treatments of getting LDL cholesterol levels even down to less than 130, it's at a level that was appreciably higher than probably we were all designed to ideally live at.
Yeah, that makes a lot of sense when you spell it out that way. And so we're kind of talking about risk assessment, and that's something that you guys brought up earlier in the kind of big changes within the guidelines. But how do we really redefine risk assessment in these guidelines, particularly the prevent score that we talked about briefly? And in a clinical setting, what should clinicians do when patients fall in these gray zones? How do you approach gray zone patients? And we'll start with Dr. Gluckman.
Yeah, so I think a couple of things is it's tools that we develop should be able to be practically applied. So I think one of the challenges, and this was true when the pooled cohort equations first came out, is how do we get prevent, which expands the number of data elements that we may look at by incorporating other information above and beyond that captured by the pooled cohort equations as part of the core equation. But even looking at other information around zip code, getting at social drivers or determinants of health, looking at UACR, urine albumin creatinine ratio, to further inform and refine risk. At the end of the day, since prevent has been published, but in particular, since the blood pressure and even more so the dyslipidemia guideline has come out, many of us live, smell, eat, breathe in our EHR. That's not necessarily always a good thing, but we need to find ways to be able to make it easier for not only their risk to be assessed, but also to figure out how to operationalize this and what do you do with the information. I would say a lot of clinicians and most patients don't necessarily understand how to contextualize risk. Realize if we talk about a 10-year risk being 5% in the prevent risk score, what does that mean? And if you understand that 5 out of 100 people over a 10-year period will go on to have a fatal or non-fatal, in the case of an ASCVD risk, a heart attack or stroke, the question then is, am I one of the 5% who will or the 95% who won't? And so it's really about framing risk for individuals, knowing that I can't with definitive sake understand and explain to the individual which group they're in. Now, the reality is as their projected risk goes up, there's a higher likelihood that they will be in the category of an individual that is going to have one of those events. And so pictographs or other ways in which to display and have patients understand risk, I think can be really, really important in helping to inform that decision. And then just to add one more thing is all of this should be about shared decision making. And so individuals that are at particularly high risk, it's helping them understand that risk and what they can do to help mitigate that risk. Again, lifestyle first, and then where drug therapy, pharmacotherapy has a role. I will say that the gray zone, so using cut points of less than 3, 3 to 4.9, 5 to 9.9, greater than or equal to 10%, the new cut points for defining low, borderline, a intermediate risk, and then a high risk categories for prevent is something that's new because people over time understand the risk thresholds in pooled cohort equations. They're different, but
Mhm.
also understanding where risk enhancers can make a difference. So more and more, I find myself inventorying and talking to patients about things that we may not have talked about as much. Does your family history make a difference? You bet it does. Does your ancestry or having high risk ancestry make a difference? Do reproductive risk factors make a difference? Premature menopause, having gestational diabetes, those are preeclampsia or eclampsia during your pregnancy makes a difference overall. What role does inflammation, subclinical, but also overt, having a history of concurrent psoriasis, psoriatic arthritis, rheumatoid arthritis, and then lastly, where other biomarkers may make a difference as a complement to informing your risk? More often than not, these help to inform an escalated risk that may not be taken into consideration by a prevent risk score, but individually, and certainly if you have more than one of these, can make a world of difference.
Keerthana, maybe I'll just add, a lot of clinicians, we always think about the CHADS-VAS score. That's how we look at whether or not we give oral anticoagulation. It's a simple thing, but it's sort of crude. Whether it's you have a CHADS-VAS score of 2 or 3, it's still not, is it really that much difference between a 2% versus a 3% risk per year of a stroke? And I think I look at the prevent score as an educated guess, and we can personalize things much better if a person has one or more of these risk enhancing factors. I think most cardiologists, by the time we turn 50, have given serious thought to going on pharmacotherapy for their cholesterol if the numbers aren't optimal and if they have any other risk factors for heart disease. But Ty brings up a great point that, people will come at this from different points of view. If you have heart disease in your family, you may be very motivated to do whatever you can to get your numbers optimized. But if you have no family history of heart disease and you don't know anyone who's had a heart attack or stroke or bypass surgery or things like that, having a 5 or 10% risk over the next 10 years is not too inspiring to make a major change by, improving one's lifestyle appreciably or starting on medication. And some clinicians will say, well, 10% is too low. Maybe if it's 15 or 20%, then I'll pay more attention. That's something that's part of the clinician-patient discussion. What Ty and I and others on our prevention dream team tried to do was to give some sort of context of what we thought were good classification levels, and at least to start that conversation.
And I may just add one more thing is, I think it's probably well understood by a lot, but not all, is that age is probably the single greatest contributor to risk. And the challenge is, maybe all of us don't feel invincible, but many of us do when we're in our 20s and 30s. And yet we're exposing ourselves in cases of elevated LDL cholesterol to a very strong risk factor that a lot of people have contextualized similar to pack years of smoking. It's the magnitude of elevation of your LDL cholesterol and the years of exposure to it. So I think the other important piece that we don't address as much is more of a lifetime risk assessment of, okay, you have low near-term, shorter-term risk, but your risk is appreciably higher when we start looking over a longer time horizon. Now, that doesn't mean every 20 or 30-year-old or 40-year-old is going to be signing up to get their risk assessed, but understanding your risk even at a point when you are vulnerable to sort of laying down the framework of perhaps less healthful behaviors. We can't change who our parents are. We may not be able to control all the conditions that we develop over our lifetime. But if you can make a difference through diet, lifestyle, and where appropriate, drug therapy, it may well be able to change the trajectory. Now we're talking about appreciably greater numbers of individuals relative to what we think about in secondary prevention.
And one other point, Keerthana, I think a big advantage of the prevent score is that if you're age 30 to 59, we have a robust estimator now for 30-year risk. So a lot of times we'll have a patient who's 35 or 40 and, maybe a 3% 10-year risk, but their 30-year risk is more like 35 or 40%. And that gets their attention much more than what their short-term risk is. So completely agree with what, Ty said that, having that LDL that's persistently 140, 150 is a risk factor, a strong risk factor over the long run, especially if there's other traditional risk factors that that person has.
Yeah, absolutely. I was just going to say that I have those 30 and 40-year-old patients coming into clinic, and even like my friends that are asking and reading and wanting to know more about, especially their prolonged lifetime risk, because the 10-year risk really doesn't seem as applicable to some 20 and 30-year-olds, maybe even 40-year-olds. So that was a big thing that I've seen in clinic myself with kind of having that more lifetime risk estimate can really make a difference for your behaviors today instead of waiting for something to happen.
Absolutely.
I want to ask a couple questions about LP little a and apoB. So, how are we integrating LP little a and apoB into this really practical risk stratification framework without overcomplicating the care and without, patients feeling like there's a lot to understand? And I'll start with Dr. Blumenthal on that one.
So with LP(a), we felt it was important to give some context. Probably the three of us have all seen patients that come in with a LP(a) of 130 nanomoles per liter, and they've been led to believe that they now have a 50% chance of getting a heart attack or stroke. But in reality, a value of around 125 nanomoles per liter is associated with maybe a 40% increased risk. So what does that mean? Well, it means if your estimated risk was 10%, it's now 14%. You don't go from 10% to 50% with a value of that of around 125. And for a person who has an LPLA of 250, that's associated with about a doubling of long-term risk. But in my mind, it's the best genetic factor that we have, and it's a simple test, and we recommended that it be done once in every person's life. It's a strong risk enhancer, and it helps drive the atherosclerotic process and also increases one's risk of aortic valve calcification and later stenosis. The apoB, I usually explain to patients, is that it's probably a little bit more precise measurement of the bad LDL cholesterol, but it doesn't need to be measured every single time. We wanted to get to our LDL targets first, and for many people, that's an LDL of less than 70 or less than 55, and we made the apoB targets the same. If your LDL targets less than 70, your apoB targets less than 70. There's some strange things with apoB because once you get down to an LDL of around 70, and then you further drive down the LDL, the apoB doesn't drop nearly as much. So you can there's some some a little bit perplexing results sometimes for clinicians, but we felt that it's at this point in time it's reasonable to first get your LDL less than 55 in a very high risk person, and your apoB also less than 55. So selective use of selective use of apolipoprotein B and more universal measurement of LP(a).
Yeah, and I would just add, the LP(a) may help to actually explain and give some sense of understanding for people in particular that have had premature events, lacking a lot of the traditional risk factors. So it can help in that way. The other thing is it gives insights about intensification of therapy. And potentially what therapies we may choose from when intensifying someone's LDL cholesterol lowering regimen. Again, I think of it as another risk enhancer. It's labeled as such in the guidelines. Now, that's all in advance of what may be a future podcast in talking about, an area of active investigation about specific new therapies that are in development targeting LP(a). I don't want to get over my skis here, so more to come in that regard. And again, although LDL cholesterol may perform less well as a predictor of atherosclerotic atherogenic risk in individuals that have elevated triglycerides, diabetes, or even on the LDL cholesterol on the low end, we more, as Roger shared, we have non-HDL cholesterol, and that comes standardly with all of our lipid profiles, and we provide goals for that. There can be circumstances of discordance between non-HDL and apoB, and those tend to be consolidated in the same people that Roger shared as well. So again, selective use, and it may inform treatment decision-making. I'll also come back to at least things like apoB. One should be measuring it if, in fact, one's going to do something with the information. So increasingly measuring for measuring's sake, and I would apply that to coronary calcium scores as well. If it's not going to, at the end of the day, change things for you as a clinician or for the patient or for both of you, I'm not going to say why have that information, but hopefully every test that we order in medicine is helping to inform us in a way that might change our approach.
Yeah, thank you so much for those comments. I think the point you made right at the end is so important too. We're not just ordering tests for the sake of ordering, but really to understand a patient's total risk, especially in the patient population where they lack the traditional risk factors, is definitely something that comes to mind for me. So I thought we would switch it up a little bit and do a quick little rapid fire. So I'm going to ask a question or say a statement, and either Dr. Blumenthal or Dr. Gluckman, you can just kind of say the first thing that comes to your mind when it comes to this. So the first point I'm going to say is lower cholesterol is better, true or false?
I would say it's definitely true, and lower for longer is better. But Ty, what are your thoughts?
No, I agree. I mean, I think that is a theme. I'll just say I'll reinforce that people worry, is there such a thing as too low? I'd say in a simple, maybe that's your next question. The answer is, I don't think that that's the case as far as we know overall. It may not be cost effective for everybody but I would agree that lower for longer is in fact better. We know that higher for longer is not the right answer.
Lower is better, longer. I like it. Okay. And then what is one healthy habit that you counsel your patients on that you also participate in regularly?
This is something that I don't do as well. I think we underappreciate the value of sleep. It is one of life's essential eight. I actually was going to start in what I could heed the warning by listening to this podcast and actually do better on. But I think sleep is so underappreciated as a key healthful behavior that the absence of good healthful sleep can have significant consequences across wide-ranging conditions, including many areas in cardiovascular medicine.
Yeah, I guess I would say since pretty much all of our patients use a smartphone, that heart app on our smartphone can tell us the number of steps that we do. And I think it's really useful for people to say, I'm going to try to aim for a minimum number of steps, even on my busy days, of 5,000 steps. That's about 2 miles. And the weekends, I'm going to, try to get at least 10,000 steps. And I think trying to walk at a brisker pace is really important. And, we're all busy in our lives, but, I think when you have that opportunity to play tennis or walk the hilly golf course at a quick pace, those are good things to try to do.
Yeah, absolutely. I will admit, I think sleep is one I need to work on too as a fellow. But now that it's getting sunny and beautiful here in Seattle in the Pacific Northwest, I'm hoping to be out and about and walking around more. What is one practice change that you think every clinician, if they aren't already doing, should really try their best to do in the clinic with their patients?
I'm going to say I think being able to have cardiovascular disease, again, number one killer for men and women. And I think having people understand their risk, I think we have learned in cardiovascular medicine that our ability to, in and of ourselves, estimate risk, we do a less than stellar job. This applies back to Roger's example of atrial fibrillation. There's actually data behind this that we tend to underestimate stroke risk and overestimate bleeding risk. I would say if we didn't formally go about assessing risk in cardiovascular medicine, if we don't already, we're probably not doing as good as we otherwise could by our patients and being able to help inform them. Because I think once we begin to appreciate someone's underlying risks, we would probably take different actions. We've seen this in understanding people's risk with chronic kidney disease, in heart failure, in atherosclerosis. So if you're not giving people that perspective or not doing it as a matter of routine, how do we make it simple and easy for you to do it? And again, it comes back to all of this should be done with support from our EHR in ways, if you will, the little person who's tapping me on the shoulder that says, hey, Ty, this person's sicker than you think they are. It might involve us reacting differently or responding differently to our education and our steps that we take in mitigating that risk.
Yeah, I think I would certainly agree with all of that. And I think I hope clinicians will, realize that most of these risk estimates that people are going to get, especially when they're less than age 50, are going to be, very low. But the presence of any risk enhancers can be used to help motivate a person a lot more. And we have more and more data that those individuals who are more physically fit, who make the time to do exercise, not only live longer with less cardiovascular disease, but fit individuals seem to get less atrial fibrillation, and in some studies suggest they also are less likely to develop conditions such as cancer. So I think trying to motivate people to improve their lifestyle habits, and I at each and every visit, I try to think about and brainstorm with the patient, what can they do better from a lifestyle point of view before that next visit? So maybe it's going to be more days a week of getting 5,000 steps or 7,500 steps a day. Those are the kind of things that people can do. Maybe brainstorm with them that, they could really get to the gym Saturdays and Sundays, and maybe do brisk walks during the weekdays. I think those are the things, Keerthana, that we want to try to emphasize with the patients and ask them what they think they can do better on prior to that next visit.
I feel like it's been such a common theme, even throughout today's episode. The focus is always going to be on the patient. That's why a lot of us got into the field that we are in and why we care so deeply about it. And I love that we're making sure that we bring up the fact that the lifestyle stuff has to happen in combination with everything else, right? The healthy habits, the lifestyle changes, and meeting the patient where they're at and having that open discussion of what do you think you can do? And let's start small and work up to it, I think is a lot easier than kind of saying, this is the number you need to get and this is what you should do, because I think that allows a very open and honest conversation with the patient.
Well said.
True. And many people are, be a part of their lives where they have less flexibility. And but I think if you can get people to brainstorm and say, well, maybe 15-minute brisk walk at lunch is something that they could do. And maybe when they get home, using some of the exercise equipment for 10 or 15 minutes a few days a week is a good starting point. And then our hope is that once they get hooked on doing some of those better health behaviors, that they'll continue doing that. And they'll find that it also decreases their stress level.
Yeah, we've briefly touched on the coronary artery calcium score, but I did want to ask kind of a question about its role within the guidelines. So where we've kind of touched on this briefly, but where do we see the role of the coronary artery calcium score? Who truly benefits from it? When does it add value? When is it maybe something that we don't order, if that ever is a chance? Because as we've talked about, we everything that we order is with the intention of learning more about a patient's risk. And so I'll start with Dr. Gluckman with that question.
Yeah, I mean, it really is a means of helping to refine risk estimates and determining, in particular, pharmacotherapy decisions. I mean, the hope is that we're embedding and activating patients, engaging them in their care to take healthful steps from a lifestyle perspective, irrespective of what someone's coronary calcium score is. So let me take a step back and answer it a different way to say, in secondary prevention, we know someone's had an event, they warrant lipid-lowering therapy. We're not doing an assessment of coronary artery calcium in that group. Coronary artery calcium can help across the sort of continuum of primary prevention individuals. Now, to be clear, patients with severe hypercholesterolemia may have clear direction about what needs to get done for that individual overall. Ultimately, at the end of the day, this is for me a sort of, is this patient going to be initiated on lipid lowering therapy? We're talking about starting with statins or not overall. I'll also add just a few more other important pieces that maybe get underappreciated overall. And I don't want to get off topic and say there is some data looking at potentially the role of adjunctive use of other risk reducing therapies like aspirin based on coronary calcium scores. I'll put that one in the parking lot, at least for purposes of today's discussion. We know from great observational data that coronary calcium scores of 300 or greater, those patients have a risk trajectory analogous to secondary prevention patients, people who have already had a prior event. It's a high-risk patient population and certainly informs the discussion. It also, for our guideline, informed, again, coming back to this theme, matching the intensity of your LDL cholesterol to your baseline risk. Two important things I just say practically overall, and then I'll turn it to Roger, who spent and dedicated a career to this, is if someone's already going to be on lipid-lowering therapy and is already receiving statin therapy, repeating coronary calcium assessments don't make sense. So if this was the means by which to getting people on lipid-lowering therapy, please don't repeat it. It can be more confusing than helpful. And I do see patients who self-refer themselves can find a way to get a referral or go out and get it themselves without needing a referral. They come back with a higher score. And then there's a worry that A, whatever they're doing isn't working, or it can confuse the situation overall. So that's a population whom I don't advocate for repeated testing because it's more to sort of determine the appropriateness of upfront testing. The second thing is I do have a conversation in front in understanding what they're going to do based upon this. So in a non-zero coronary calcium score, there's good clarity about beginning as a complement to lifestyle therapy, drug therapy with a statin. And if a patient says, no matter what, I will not go on drug therapy, you're not going to convince me otherwise, maybe this is the difference between them making the types of aggressive, intensive lifestyle changes that Roger already spoke about. But if it doesn't, does that information that we're going to get back, is that going to change someone's behavior and dedication to either lifestyle or initiation of their drug therapy? If the answer is no, then I think I need to pause for a second. Despite low risks and low cost to the test, it may not be the right test for them. Roger, what do you think?
No, totally agreed, Ty. And one thing that we didn't talk about is the finding of incidental coronary calcium, Keerthana. So there's again robust data to indicate that if you have moderate or advanced coronary calcium on a standard chest CT, that your risk is quite high, similar to someone who has stable coronary heart disease. And there's approximately close to 20 million chest CTs done in this country. I usually say 1 million of those chest CTs are ordered by the Johns Hopkins Osler Medical Health staff. They have a very low threshold to get a chest CT. We've learned over the years, especially from our friends at Stanford, that the presence of incidental coronary artery calcification can be a really good motivator, and it is associated with a much higher risk. So, and in terms of another caveat about why we don't recommend repeat coronary calcium scores in individuals who already have coronary calcium is that the scores may go up just because more of the existing plaque becomes calcified and thus more stable. It's not that they have more plaque, and people don't realize that. And there's plenty of people who, Ty and I have seen who, when they first came to us, had coronary calcium scores over 1,000. And they're doing really well with good medical and lifestyle therapy. So there's not a one-to-one relationship between having a high calcium score and having a cardiovascular event, but it does indicate that these people have the substrate to develop significant cardiovascular disease. And if we can, work on the better control of lipids and blood pressure and blood sugar and improve their lifestyle habits, then I tell patients we have a good chance of stabilizing their advanced subclinical atherosclerosis.
And I'll just add one more thing. Roger, you brought up a great point about the non-dedicated CT scan for evaluating coronary calcium. I find myself now going back and somebody, as the U.S. Preventive Services Task Force recommends, using low-dose CT scans for cancer screening for lung cancer in those who are prior smokers. But I'll also go back to individuals in their 40s or 50s may have landed in the emergency department with shortness of breath and had pneumonia. And are there insights or some, at least a view into their vasculature by looking at their coronary calcium on a non-dedicated study? But you look back and you said, wow, lo and behold, months, years, and in some cases, decades before I'm meeting them, you're finding out that they actually had evidence of subclinical atherosclerosis. And that is a good thing to share with patients so that they can actually look back and help them understand that this has been a longstanding issue for them and we can change the natural history, but it also may be something that helps to define adjunctive drug therapy as well.
That is a great segue right into like a conversation about cost, access, and adherence for patients, especially with some of these newer therapies and especially the adjunct therapies that we're learning about and we're introducing as our toolbox grows. And so, what are your recommendations for clinicians how to navigate those sort of access issues, adherence challenges, and cost while also trying to do right by the patient? And I'm sure it's a question with a million different answers, and maybe there's not even a perfect answer, but what are some approaches that we can use in our clinics from both of you? And we'll start with Dr. Blumenthal.
So, and I'll go back to the coronary calcium scores. We're not advocating that for everyone in primary prevention. And in my mind, my personal bias is if people's LDLs are above 100, despite sustained attempts at lifestyle improvements, and they have another risk factor or a risk enhancer, that might be enough for me to try to convince them to say, yeah, we ought to strongly consider, going on a medication. And sometimes it doesn't have to be a daily medicine. We have a lot of data with statins that 3 times a week we can get the LDL down by about a third. So sometimes people who say, Dr. Blumenthal, I can't picture myself going on a prescription medicine daily. That's an option that we might give. Um, I think that luckily with the Prevent score, we have a more accurate risk assessment tool based on 6.6 million people. The pooled cohort equation was based on 26,000 people in NIH-sponsored studies. And the Prevent score is a more contemporary set of data, and I think it's a very useful way to get a good educated guess. But we try to personalize, we delve into the family history. So again, I don't order many coronary calcium scans, but it's usually in those patients where, they're on the fence or they're inclined not to go on a medicine. But if the knowledge of that they have moderate subclinical atherosclerosis would motivate them to start a medicine, then that's the perfect person, I think, to try to order that type of scan on.
And I agree completely. I'll just say that, it varies market to market that I've lived in terms of payer coverage. I'm now focusing on coronary calcium scores or scans to get a score. In some cases, we've seen broader coverage. In other cases, patients are asked to pay out of pocket for this. I think the good news is it's a low cost, easily accessible test. And I'm going to use in not formal ways, but just say, I think that there's good value for the test in informing a decision that you're really talking about in those certainly that have a non-zero score. It's one and done for answering the question. For those with a score of zero, we do in the guidelines give a 3 to 7 year window of repeat. I split the difference and call it 5 years, but I think that there is a opportunity to be able to look at that. My hope is that we see expanded recognition of the role for this. And to Roger's point, it might be, boy, my coronary calcium score is not zero. I knew for a long time there were things that I could do better from a lifestyle standpoint. This now reinforces for me that I actually have atherosclerosis. And knock on wood, it will never be consequential for me, but I want to be darn sure that I'm doing everything within my power to tilt the sort of scales in my favor as far as that's concerned. So, again, I'm not the busiest orderer of the test, but I do think it plays a key role and helps to provide a lot of information in a relatively short and relatively inexpensive test.
Yeah, thank you so much. I'm going to shift gears a little bit here. And I know we briefly touched upon adverse pregnancy outcomes, but I just wanted to talk about how the guidelines and what are your recommendations for addressing lipid management in women and how we incorporate some of these history, including adverse pregnancy outcomes and pregnancy history, and into our patient risk understanding, especially for cardiologists that are maybe afraid to ask about a woman's pregnancy history or not sure where to start with that.
I'm happy to start and just say, there is an entire now subspecialty that is focused on cardio obstetrics. My sense is it's disproportionately focused on a someone who may be pregnant at that time and how we're best managing and supporting them early in their pregnancy, throughout the pregnancy, and beyond the pregnancy. But being a part of the guideline itself has reinforced for me that there are reproductive risk factors that I need to ask about. And so someone I'm meeting who's in their 50s or 60s who may have been pregnant 20 years, 30 years or more earlier, that history is relevant. And so I guess I would just say that uh, untoward events that occurred during pregnancy, preeclampsia or eclampsia, gestational diabetes, inform the risk of that individual over a much longer time horizon. Premature menopause, so now years later, that someone may have also informs their risk. And it all comes back to what I would say we probably downplay, but is super important is taking a really good history. I know many of us are challenged in the amount of time that we're allowed to spend with patients. And I say allowed, it's just we have a scheduled time period. No one's standing over with a clock, but we're challenged by how do we see the next patient and the next patient in clinic and get through our busy day. And this is really for a moment to pause and say, things like a family history of premature cardiovascular disease, doing an inventory of reproductive risk factors is more important than some of the other things that we may ask about. And it gives us insights into the patient, not just now, but later on as well.
Totally agree. I think, if a person has gestational history of gestational diabetes, pregnancy-associated hypertension, all these things are important. And, when we do a review of systems, I think it's good to ask about all those points. And, it doesn't mean that if you had a pregnancy complication, or if you had have a reproductive risk marker, you're necessarily going to go on a medication right away. But we can tell the patient that statistically, just like if they have a high LPLA, having reproductive risk markers may be associated with potentially close to a doubling of estimated risk. And we want to improve their lifestyle habits. And if we can't get to our target goals with lifestyle alone, then the judicious use of medicine is really the next step.
Yeah, thank you so much for those thoughts. So, coming towards the end of our episode, I guess the question I have is what unanswered questions remain after our guideline update, and what upcoming trials, therapies, or initiatives are you most excited to see about that you think could shape the next iteration of the dyslipidemia guidelines? Or what are your hopes for the next round?
So we have to be always cognizant of cost effectiveness. And one challenge in interpreting the Vesalius study is that they were looking at an LDL of 45 versus about 110. They weren't looking at 45 versus 75. So it may very well be that, that patient who we get down to an LDL of, say, 60 or 65, do we really need to maybe utilize a more expensive medicine like bempedoic acid or a PCSK9 inhibitor to get down to 45? And or maybe with the limited amount of dollars that we have, and an overweight person who has prediabetes, that maybe a GLP-1 receptor agonist might be a better choice than doing a more expensive lipid-lowering medicine. So we have to be careful, as Neil Stone, who has been a mentor to both Ty and to me, has always said, what is the return for the incremental potential benefit? The cost is so really important. And, in 2018, we thought that there was a question mark in terms of the cost effectiveness of PCSK9 inhibitors based on the existing data with the Fourier study, et cetera. And I think we need to be, thinking of that. So strategy trials are going to be, really important, and look forward to getting more insight into how to spend limited healthcare dollars.
I couldn't agree more. I guess I'll just add two different things. We talked about tools in the toolbox. Today, we've got great tools in the toolbox, and we can achieve the lipid targets with essentially everything we have, with some rare exceptions. Patients with the most severe, usually familial forms of elevated LDL cholesterol, and or challenges in patients having tolerability or ability to get on some of these therapies. We're going to see an expanded array of LDL cholesterol lowering agents added to the mix, potentially an introduction, potentially, of LP little a lowering agents, potentially expanded utilization of therapies that can lower triglycerides. And so if some is good is more better, how do we individualize and move towards a more precision medicine approach? for lipid management. I'm now expanding beyond just LDL, but to Lp(a), and triglycerides as potential therapeutic targets. I will also just fundamentally say that, this has been an honor to work with Roger and many other people on the guideline. But I'd like very much, more than anything else, not to be sitting back 5 years from now and saying, boy, we have opportunities to implement lifestyle changes and base therapies that we have available. And I believe at its core, we have a systems-based problem in this country. We probably are not incented the way that we should to focus on prevention. And yet, as much as 80% of cardiovascular disease is preventable, the way that we deliver care today clearly isn't working as well as it could and should to address blood pressure, lipids, and many other risk factors. And so how do we re-engineer care going forward? And so I think more and more focus about what do those teams look like, who sits on these teams, who's helping to develop care pathways and protocols as we manage populations as a whole. I can assure you that if tomorrow we were reimbursed more for focus on prevention rather than the end manifestations of cardiovascular disease, we'd find ways to do this better, at least, than we do today. So I'd like to see us focus much more on how care is delivered with tools that we have, perhaps to a much greater degree than just focused on developing more tools for the toolbox.
Thank you both so much. What an incredible honor to be able to be sitting here and talking to both of you. And I know we could have kept this conversation going to a lot more different topics, and we've really just scratched the surface of the dyslipidemia guidelines. But I do know that a lot of trainees and other clinicians who are listening to this will definitely feel like they've gained a lot of knowledge about practical tips, but also what to look for in their patient encounters. I know that I have. And it was truly a pleasure to get to discuss with both of you. And I'm so grateful that you took the time to have this conversation.
Well, thanks.
Pleasure was all
Keerthana.
mine.
You did a great job.
Thank you so much for listening. To learn more about the ASPC, please visit our website at aspconline.org.